Ectopic pregnancy is a very high-yield topic on the USMLE Step 2, and we're going to be discussing risk factors, presentation, diagnosis, and management of the ectopic pregnancy. Let's start with a question that we could see on the Step 2 exam. A 29-year-old woman with a history of chlamydia and abnormal vaginal bleeding presents with left lower quadrant abdominal pain for the last 8 hours. Her last menstrual period was 6 weeks ago. Her vital signs are given to us, and they appear to be stable. Which of the following is the most likely diagnosis? Ectopic pregnancy, menstrual cramps, diverticulitis, ovarian torsion, or ovarian cyst? The correct answer in this case will be ectopic pregnancy, and there's a number of clues given to us in the question stem, and we'll go over them in just a minute. Menstrual cramps are not typically associated with an altered menstrual pattern. Diverticulitis, ovarian torsion, and ovarian cysts are not associated with vaginal bleeding. And in fact, diverticulitis typically causes left lower quadrant abdominal pain and rectal bleeding, not vaginal bleeding. The definition of ectopic pregnancy, also called an extrauterine pregnancy, is one in which the blastocyst implants anywhere other than the endometrial lining of the uterine cavity. 98% of ectopic pregnancies are going to occur in the fallopian tube, with 80% of those occurring in the ampullary segment of the fallopian tube. Ectopic pregnancies are not that uncommon, accounting for 1 to 2% of pregnancies in the United States. The Step 2 exam likes to ask questions that ensure that you understand the pathophysiology of the disease process, so it's important to understand the risk factors for ectopic pregnancy. Previous ectopic pregnancy is the strongest risk factor for subsequent ectopic pregnancy. Pelvic inflammatory disease is another common risk factor, and in fact, due to increasing chlamydial infections, ectopic pregnancy is on the rise. A commonly tested risk factor is intrauterine devices. Seen on the left, we see a flat plate of the abdomen with a Paragard IUD in the uterus, and on the right, a model with a Mirena IUD in the uterus. Now, it is important to remember that the overall incidence of ectopic pregnancy in women with an IUD is decreased because the overall incidence of pregnancy is decreased. However, if you become pregnant with an IUD in place, your risk for ectopic pregnancy is increased. There is a common physiologic connection here, and something that could be helpful on the test. A common risk factor is that of tubal damage, or anything that interferes with normal implantation. So other things, such as endometriosis or prior tubal surgery, can also be ectopic pregnancy risk factors. The presentation of ectopic pregnancy on the board exams is going to be very similar to our patient in the practice question. There will be some period of amenorrhea, unilateral lower abdominal or pelvic pain, and abnormal vaginal bleeding. The clinical manifestations typically appear 6 to 8 weeks after the last normal menstrual period, but they can occur later, especially if the pregnancy is not in the fallopian tube. Normal pregnancy discomforts, such as breast tenderness, frequent urination, and nausea, are often present in addition to the symptoms described here. If the ectopic pregnancy is ruptured, they may give you additional symptoms, such as abnormal vital signs, or peritoneal signs, such as rebound and guarding found on the physical exam. But remember, with the classic triad of symptoms of abdominal pain, amenorrhea, and vaginal bleeding, be thinking ectopic pregnancy. The differential diagnosis of a woman presenting with lower abdominal pain is quite broad and includes an abortion, acute appendicitis, adnexal torsion, a corpus luteum cyst rupture, diverticulitis, endometriosis, gastroenteritis, pelvic inflammatory disease, or a urinary tract infection. In addition, vaginal bleeding has several pregnancy-related and non-pregnancy-related etiologies. It's important here to make our workup simplified. A pregnancy test is important in all premenopausal women who present with abdominal pain or vaginal bleeding in order to guide the direction of future workup. The diagnosis of ectopic pregnancy is based on a combination of a beta-HCG, which confirms pregnancy, and a high-resolution transvaginal ultrasound, which enables the location of the implantation site to be determined. These two tests enable the early diagnosis of ectopic pregnancy, ideally before the tubal rupture. The transvaginal ultrasound is going to be the most useful test for determining the location of the pregnancy. If this type of an imaging study is non-diagnostic or we can't see the pregnancy, it may be because the pregnancy is too early to be visualized by ultrasound. We can confirm this by getting a quantitative beta-8CG and looking for the so-called discriminatory zone, which is the beta-8CG in which you should see a pregnancy in the uterus. The discriminatory zone is typically a serum beta-8CG of 1,500 to 2,000 international units per liter. A good clinical rule of thumb is that you should have a doubling of beta-8CG every 48 hours. So if your initial beta-8CG is below the discriminatory zone, you can reliably predict a rise in beta-8CG and determine when the discriminatory zone stipulation will be met. If a patient presents and is unstable, laparoscopy may be necessary to diagnose the ectopic pregnancy in order to visualize and remove the ectopic pregnancy in the adnexa. Here's a great example of how an ultrasound can be used to identify a pregnancy of undetermined location. In a woman who has a positive beta-8CG, we see the uterus with the arrow pointing to the endometrial cavity, which appears to be empty. On the right is the bladder, and in the posterior cul-de-sac, we see a mass which is consistent with an ectopic pregnancy. Once you've determined that you're dealing with an ectopic pregnancy on the Step 2 exam, this algorithm can be very helpful to answer questions that will follow. First, you need to determine if the patient has a ruptured ectopic pregnancy or an unruptured ectopic pregnancy. Those who have a ruptured ectopic pregnancy need to be deemed stable or unstable. Those that are stable may have peritoneal signs on physical exam, but no hemodynamic instability, and they can be taken to surgery via laparoscopy or laparotomy. If the patient is unstable, the Step 2 exam will let you know by changes in their vital signs, and answers to the questions should include resuscitation with IV fluids, blood products, or pressors if necessary, followed by surgery. If the pregnancy is not ruptured, medical or surgical treatment can be offered to the patient. While surgical approaches are the mainstay of treatment, advances in early diagnosis facilitated the introduction of medical therapy with methotrexate in the 1980s. The overall success rate of medical treatment in properly selected women is nearly 90%. Optimal candidates for medical management with methotrexate are hemodynamically stable, willing and able to comply with post-treatment follow-up, have beta-8CG levels less than 5,000, and have no fetal cardiac activity. If you're going to treat someone with medical therapy on the Step 2 exam, it's important to obtain baseline labs. A CBC ensures the patient is not too anemic for therapy. LFTs ensure there is no underlying liver disease, as side effects of methotrexate include hepatic toxicity. Kidney function tests are drawn as methotrexate is primarily excreted by the kidneys, and a baseline beta-HCG is obtained. Methotrexate is given, and the patient needs to return on days 4 and 7 for a beta-HCG level. If there is a 15% drop, treatment is considered a success, and weekly beta-HCGs are drawn until they are undetectable. If there is not a 15% drop, you have the option of giving a second dose of methotrexate as long as the patient remains stable. Again, beta-HCG levels are checked on days number 4 and 7, and if there is a 15% drop, we observe for side effects and obtain weekly beta-HCGs until they are negative. If there's persistently elevated HCG levels, it's time to proceed with surgical management. Some women are not appropriate candidates for medical therapy and should be managed surgically. The Step 2 exam may test you on contraindications to methotrexate therapy, which include hemodynamic instability, signs of impending or ongoing ectopic mass rupture, such as severe or persistent abdominal pain, or greater than 300 milliliters of free peritoneal fluid outside the pelvic cavity. Clinically important abnormalities in baseline hematologic values, renal or hepatic laboratory value abnormalities, immunodeficiency, active pulmonary disease, peptic ulcer disease, hypersensitivity to methotrexate, a coexisting viable intrauterine pregnancy, breastfeeding, patients being unwilling or unable to be compliant with the post-therapeutic monitoring, or patients that don't have timely access to a medical institution. There are a few relative contraindications to treatment with methotrexate, which include a gestational sac greater than 3.5 centimeters, or positive fetal heart activity. Now that we've discussed medical management of ectopic pregnancy with methotrexate, let's briefly discuss surgical treatment. It can be done one of two ways, either via salpingostomy or salpingectomy. A salpingostomy is done when you're trying to preserve the fallopian tube. The fallopian tube is incised, and the ectopic pregnancy is shelled out, leaving the fallopian tube behind. A salpingectomy is performed when the tube cannot be saved, and the entire tube along with the ectopic pregnancy is removed. Here we have a laparoscopic image of a left tubal pregnancy. In this case, the tube was unable to be saved, and here is a picture postoperatively after both the ectopic pregnancy and fallopian tube have been removed. A final important note on ectopic pregnancies, as this may come up on the Step 2 exam. All mothers who are Rh negative should receive anti-D-Rh immunoglobulin, or RhoGAM, so that subsequent pregnancies will not be affected by hemolytic disease of the newborn. RhoGAM needs to be given within 72 hours of onset of bleeding in order to be effective.